Welcome back to another Explainer. Today we are diving headfirst into the incredibly high-stakes world of global disease detection. It's this fascinating field of science that literally dictates human survival. Yet, it almost always operates completely in the shadows, right up until a crisis strikes. Think about it like a crime scene, but in this case, the suspect totally invisible. The weapons are microscopic, and the victims are multiplying rapidly by the hour. You obviously can't just call the regular authorities to solve something like this. So who exactly do you call? Well, you call an epidemiologist. Derived from the ancient Greek words epi meaning upon, demos meaning people, and logos for study, this field is quite literally the study of what is upon the people. It's the absolute cornerstone of public health, figuring out exactly who gets sick, when and where it happens, and most importantly, why. Here's our briefing for today's investigation. We'll cover 1. The disease detectives. 2. History of the hunt. 3. The epidemiologist's toolkit. 4. Proving cause and effect. 5. Traps, errors, and biases. And finally, 6. Securing our global future. All right, let's jump right into Section 1, the disease detectives. So what do they actually do? Well, their job goes way beyond just counting cases in a hospital ward. These detectives meticulously track the distribution of a disease, the who, the when, and the where. They're constantly hunting for hidden risk factors and determinants. Is it an environmental thing, a genetic marker, a specific lifestyle habit? To figure that out, they design really specialized health studies and then use all that hard data to shape the evidence-based public health policies that ultimately keep our communities safe. Now, to gather all this crucial evidence, they basically have two main options. Sometimes they can run experimental studies, think clinical trials, where they actually take control of the variables. But a lot of the time, especially when they're looking at harmful exposures, they have to rely on observational studies. That basically means they have to just stand on the sidelines and watch nature take its course, gathering clues without interfering at all.
Moving on to Section 2, History of the Hunt.
To really appreciate this science, we kind of need to look back at how it started. In ancient Greece, Hippocrates actually coined the term epidemic, but he blamed sickness on a weird imbalance of bodily humors. Fast forward to 1543, and an Italian doctor named Girolamo Fracastoro throws out this radical idea: invisible living particles cause disease. This was wild at the time, pushing back against the popular idea of toxic air, or miasma. But the biggest shift? That happened in 1854 in London.
Enter John Snow. No, not that John Snow. This one is widely considered the father of modern epidemiology. During a completely terrifying cholera outbreak in London's Soho district, Snow didn't just look at the sick people, he mapped them out. And he noticed this massive cluster of deaths right around a single water source. In a brilliant aha moment, he proved cholera was waterborne simply by convincing officials to take the handle off the contaminated Broad Street pump. And literally, just like that, the local outbreak ended. A real game changer.
Which brings us to Section 3, the epidemiologist's toolkit. Fast forward to today, and modern investigators essentially manipulate time using two incredibly powerful observational tools. First up, we've got case control studies. These look backward. They take sick patients and healthy controls and look into the past to see what exposures differed between them. On the flip side, we have cohort studies, which are prospective. They follow a massive group of healthy subjects forward in time, sometimes for literal decades, tracking who eventually gets sick to link it back to their lifestyle. And depending on which direction of time they're traveling, they calculate different statistics to build their case. In those backward-looking case control studies, they figure out the odds ratio. This compares the odds of a prior exposure in the sick group versus the healthy group. But if they're looking forward in a cohort study, they use the relative risk. This is a super powerful metric that tells us the actual probability of getting sick if you're exposed to something versus if you're unexposed.
Let's look at Section 4, Proving Cause and Effect. Okay, gathering the data is one thing, but proving the suspect actually committed the crime, that's the hard part. The absolutely crucial point here is that correlation does not imply causation. Just because two things show up together at a scene doesn't mean one caused the other. Disease is almost never just a simple one cause, one effect thing. It's usually this highly complex chain or web of component causes. Proving a true biological cause requires some serious rigor.
To get that rock-solid conviction, investigators rely on the 1965 Bradford Hill criteria. It's basically the ultimate checklist. They look for a really strong association,
and one that is consistent across different places. They check for specificity in the disease and population. They absolutely have to prove temporality, meaning the cause definitely happened before the effect. And finally, biological plausibility. It just has to make physical sense based on our current scientific understanding.
But it's not always smooth sailing, which brings us to Section 5, Traps, Errors, and Biases.
The path to solving a medical mystery is filled with false leads. Investigators have to perfectly differentiate between two types of errors here. First is random error. These are just natural fluctuations due to sampling variability. It's frustrating, sure, but you can usually fix it just by increasing your sample size. But systematic error or bias, that's dangerous. That is a fundamental flaw in the measuring device or study design. It skews everything. If your equipment is calibrated wrong, testing 1 million people won't fix it. You'll just have 1 million totally flawed data points.
And then there's the ultimate trap, confounding. This happens when a sneaky third variable secretly mixes up the evidence, basically framing the wrong suspect. Imagine a study showing that people carrying lighters have higher rates of lung cancer. Does the lighter cause the cancer? No, of course not. The hidden confounder is cigarette smoking. The lighter is just associated with the real culprit.
They also have to watch out for deep psychological traps, like recall bias. Take David Sackett's famous fetal health study, for example. He analyzed past drug exposures by interviewing mothers who had miscarriages and mothers with normal pregnancies. The mothers with miscarriages reported a 28% rate of past drug exposure, while the healthy group reported only 20%. But here's the kicker. When researchers checked the actual medical records, those numbers didn't match. Mothers who suffered a tragedy were desperately searching their memories for a reason why, which inadvertently skewed their reporting compared to the control group. It's a tragic, very human bias that can completely derail the data.
Let's wrap things up with Section 6, Securing Our Global Future.
194. That is the number of member states in the World Health Organization. Why does that matter? Because it represents the sheer monumental scale of global cooperation we actually need when we're facing down a biological threat that couldn't care less about borders.
You see, the global response to disease relies entirely on these nations working together. Driven by the massive disruptions and the frankly profound inequities exposed by COVID-19, these governments united. They realized individual responses just weren't cutting it. So, they drafted an international instrument under the WHO Constitution, which led to the official adoption of the Global Pandemic Agreement on May 20, 2025. And this brilliantly illustrates why all of this matters. As the WHO put it, at the heart of this agreement is the need to ensure equity and access to the tools needed to prevent and prepare for pandemics and access to healthcare for all people. The whole point of identifying disease determinants, all those cohort studies and odds ratios we talked about, is to create actionable, equitable global policies. Policies that make sure whether a pathogen strikes in London, Uganda, or literally anywhere else, every single person gets access to the tools they need to survive. So as we wrap up today's explainer, I want to leave you with a critical thought. We've seen how far this field has come since John Snow took the handle off that pump in 1854. Our disease detectives definitely have the tools to solve the mystery. But if the science of epidemiology can perfectly trace the microscopic culprits, do we have the global willpower to equitably share the cure? Think about that for a bit. Thanks for learning with me today, and keep questioning the world around you.